Hello everyone, I'm back again to give you a very brief discussion on burn injuries and its management. And I'm Ratzel Dichen, BSN4 student of CSLLFI. To begin with, if we say burn, what could be the causes of it? So wounds causing burns could be exposure to excessive heat, chemicals, fire or stem, radiation, and electricity, right? So we go to types of burns. We have thermal, which is the exposure to flame or a hot object. We have chemical or exposure to acid, alkali, or organic substances. We also have electrical, result from the conversion of electrical energy into heat. Extent of injury depends on the type of current and the pathway of flow, local tissues resistance, and duration of contact. And lastly is radiation. This results from radiant energy being transferred to the body, resulting in production of cellular toxins. We go to burn wound assessment, classified according to depth of injury and extent of body surface area involved. Burn wounds differentiated depending on the level of dermis and subcutaneous tissue involved. So some is superficial or the first degree, second is deep or second degree, and the third one is full thickness or third and fourth degree. Superficial burns or first degree. When we say first degree, epidermal tissue is only affected. Erythema, blanching on pressure, mild swelling, no vesicles or blisters initially, and not serious unless large areas involved. Like for example is sunburn. Superficial dermal burn or first degree burn. What seems to be the characteristics of first degree burn? So necrosis confined to upper third of dermis, zone of necrosis lifted off viable wound by edema, and the third one is small zone of injury. We go to deep or second degree burn. This involves the epidermis and deep layer of the dermis. Fluid-filled vesicles, red, shiny, wet, severe pain. Hospitalization is required if over 25% of body surface is involved. So example of this is star burn or flame. The characteristic of deep dermal burn or second degree burn. Necrosis involving majority of skin layers, zone of necrosis adherent to zone of injury, and smaller edema layer. Next is full thickness or third or fourth degree burns. So destruction of all skin layers requires immediate hospitalization. This is also dry, waxy white, leathery or hard skin, no pain. Exposure to flames, electricity or chemicals can cause third degree burns. So at full thickness burn or third to fourth degree burn, the characteristic is no remaining viable dermis. We go to calculation of burned body surface area. So total body surface area or TBSA, we have superficial burns are not involved in the calculation. Land and Browder chart is the most accurate because it's just for age. So rules of nines divides the body adequate for initial assessment for adult burns. Okay, so we go to rules of nines. Head and neck is counted as 9%. Each upper extremities or the arms are also 9%. Each lower extremity or the legs are 18%. The anterior trunk is 18%. Posterior trunk 18%. Genitalia or perineum is 1%. Okay, we go to vascular changes resulting from burn injuries. Circulatory disruption occurs at the burn site immediately after a burn injury. Blood flow decreases or ceases due to occluded blood vessels. Damage of macrophages within the tissues release chemicals that cause constriction of vessels. Blood vessels thrombosis may occur, causing necrosis. Macrophages is a type of white blood that ingests takes in foreign material. Macrophages are key players in the immune response to foreign invaders such as infectious microorganisms. We go to fluid shift. Occurs after initial vasoconstriction, then dilation. Blood vessels dilate and leak fluid into the interstitial space, known as third spacing or capillary leak syndrome. Causes decreased blood volume and blood pressure, and also occurs within the first 12 hours after the born and can continue to up to 36 hours. Speaking of fluid imbalances, this occurs as a result of fluid shift and cell damage, hypovolemia, metabolic acidosis, hyperkalemia, hyponatremia, hemoconcentration, or elevated blood osmolarity, or hematocrit and hemoglobin due to dehydration. In fluid remobilization, this occurs after 24 hours, capillary leak stops. You can see diuretic stage wherein edema fluid shifts from the interstitial spaces into the vascular spaces. Blood volume increases, also leading to increased renal blood flow and diuresis. Body weight returns to normal, and we can observe hypokalemia. In Curling's ulcer, acute ulcerative gastroduodenal disease occur within 24 hours after burn due to reduced GI blood flow and mucosal damage. Treat clients with H2 blockers, mucoprotectants, and early enteral nutrition. Watch for sudden drop in hemoglobin. Let's proceed to phases of burn injuries. We have emergent, 24 to 48 hours, acute, and rehabilitative. In emergent phase, it's an immediate problem, which is the fluid loss, edema, reduced blood flow, fluid and electrolyte shifts. The goal is to secure airway, support circulation by fluid replacement, keep the client comfortable with analgesics. We have to prevent infection through wound care and maintain body temperature and provide emotional support. Knowledge of circumstances surrounding the burn injury. We have to obtain client's pre-burn weight, dry weight to calculate fluid rates. Also, calculations based on weight obtained after fluid replacement is started are not accurate because of water-induced weight gain. Height is important in determining body surface area, or BSA, in which is used to calculate nutritional needs. We have to know client's health history because the physiologic stress seen with a born can make a latent disease process develop and symptoms. What could be the clinical manifestation in the emergent phase? So, clients with major burn injuries and with inhalation injury are at risk for respiratory problems. Inhalation injuries are present in 20% to 50% of the clients admitted to burn centers. So, assess the respiratory system by inspecting the mouth, nose, and the pharynx. Burns of the lips, face, ears, neck, eyelids, eyebrows, and eyelashes are strong indication that an inhalation injury may be present. So change in respiratory pattern may indicate a pulmonary injury. The client may become progressively hoarse, develop a brassy cough, drool, or have difficulty swallowing, produce expiratory sounds that include audible wheezes, crowning, and stridor. Upper airway edema and inhalation injury are most common in the trachea and main stem bronchi. So auscultate these areas for wheezes. If wheezes disappear, this indicates impending airway obstructions and demands immediate intubation. Cardiovascular will begin immediately, which can include shock. And shock is a common cause of death in the emergent phase in clients with serious injuries. So, obtain a baseline ECG to monitor for edema, measure central and peripheral pulses, blood pressure, capillary refill, and pulse oximetry. We also have these changes in renal function, which is related to decrease of renal blood flow. Urine is usually highly concentrated and has a high specific gravity. Urine output is decreased during the first 24 hours of the emergent phase. So fluid resuscitation is provided at the rate needed to maintain adult urine output at 30 to 50 ml per hour. So you have to measure BUN, creatinine, and sodium levels. We also have sympathetic stimulation during the emergent phase, causes reduced GI motility and paralytic ileus. You have to auscultate the abdomen to assess bowel sounds, which may be reduced. We also have to monitor for nausea and vomiting and abdominal distension. And clients with burns of 25% total body surface area or who are intubated generally require a NG tube inserted to prevent aspiration and removal of gastric secretions. In skin assessment, you have to assess the skin to determine the size of depth of burn injury. So the size of the injury is first estimated in comparison to the total body surface area or TBSA. For example, a burn that involves 40% of the TBSA is a 40% burn. So you use the rule of nines for clients whose weights are in normal and proportion to their heights. Using IV fluid therapy, infusion of IV fluids is needed to maintain sufficient blood volume for normal CO. So clients with burns involving 15% to 20% of the TBSA required IV fluid. So purpose is to prevent shock by maintaining adequate circulating blood fluid volume. So severe burn requires large fluid loads in a short time to maintain blood flow to vital organs. Also, fluid replacement formulas are calculated from the time of injury and not from the time of arrival at the hospital. Diuretics should not be given to increase urine output. Change the amount and rate of fluid administration. Diuretics do not increase CO. They actually decrease circulating volume and CO by pulling fluid from the circulating blood volume to enhance diuresis. What are these common fluids? So we have proteinate or 5% albumin in isotonic saline or 1/2 given in first 8 hours. Then another 1/2 is given in the next 16 hours. So we also have LR or lactated ranger without dextrose. 1/2 is given in first 8 hours and the other half is given in next 16 hours. We also have crystalloid or hypertonic saline. So we adjust to maintain urine output at 30 ml per hour. And next is crystalloid only or lactated rangers. What are these common fluids? So we have proteinate or 5% albumin in isotonic saline or 1/2 given in first 8 hours. Then another 1/2 is given in the next 16 hours. So we also have LR or lactated ranger without dextrose. 1/2 is given in first 8 hours and the other half is given in next 16 hours. We also have crystalloid or hypertonic saline. So we adjust to maintain urine output at 30 ml per hour. And next is crystalloid only or lactated rangers. What would be the nursing diagnosis in emergent phase? We have decreased carbon oxide, deficient fluid volume related to active fluid volume loss, ineffective tissue perfusion, and ineffective breathing pattern. So we move to acute phase of burn injury. Lasts until wound closure is complete. The care is directed toward continued assessment and maintenance of the cardiovascular and respiratory system. Pneumonia is a concern which can result in respiratory failure requiring mechanical ventilation. Infection and topical antibiotics like Selvadin and tetanus toxoid So we have to weight the patient daily without dressings or splints and compare to preborn weight. 2% loss of body weight indicates a mild deficit, and a 10% or greater weight loss requires modification of calorie intake. We also have to monitor for signs of infection. Local and systemic signs of infection or gram-negative bacteria. We have Pseudomonas or Proteus may lead to septic shock. So conversion of a partial thickness injury to a full thickness injury. So ulceration of health skin at the burn site. We have erythematous or nodular lesions in uninvolved skin, excessive wound drainage, odor sloughing of grafts, or slouching of grafts rather, altered level of consciousness, changes in vital signs, oliguria, GI dysfunction such as diarrhea, vomiting, and metabolic acidosis. Lab values, we have sodium, for sodium, hyponatremia or hypernatremia. In potassium, we have hyperkalemia or hypokalemia. WBC is white blood cells, 10,000 to 20,000. What could be the nursing diagnosis in acute phase? We have impaired skin integrity, risk for infection, imbalanced nutrition, impaired physical mobility, disturbed body image. Planning and implementation, non-surgical management, removal of exudates and necrotic tissues, cleaning the area, stimulating granulation and revascularization and applying dressings. Debridement may be also needed. So in dressing the burn wound, after burn wounds are cleaned and debrided, topical antibiotics are reapplied to prevent infections. So standard wound dressings are multiple layers of gauze applied over the topical agents on the burn wound. So rehabilitative phase of burn injury. So we started at the time of admission, technically begins with wound closure and ends when the client returns to the highest possible level of functioning. They have to be provided psychosocial support, assess home environment, financial resources, medical equipment, and prosthetic rehabs. So health issues should include symptoms of infection, drugs, regimens, appointments, follow-up checkups, appointments, comfort, measures to reduce pruritus. So in diet, initially NPO, begin oral fluids after bowel sounds return. Do not give ice chips or free water, lead to electrolyte imbalance and high protein or high calorie. So in goals, we have to prevent complications, of course, contractures, vital signs early. It's important. Assess respiratory function, tetanus boosters, anti-infection, analgesics, no aspirin, strict surgical asepsis, turn every after 2 hours to prevent contractures, and emotional support. In debridement, done with forceps and curved scissors or through hydrotherapy or application of water for treatment, only loose eschar removed. Blisters are left alone to serve as protector and controversial. And skin grafting, this is done during the acute phase, used for full thickness and deep partial thickness wounds. We also have post-care of skin grafts. So maintain the dressing, use aseptic technique. Graft should look pink if it has taken after 5 days. Skeletal traction may be used to prevent contractures. Elastic bandages may be applied for 6 months to 1 year to prevent hypertrophic scarring. And that's all. I hope you have learned something. And thank you. Good day, everyone.